Thank you, everybody, for coming to our marquee alumni weekend event, Health Tech Horizons, Innovations for a Healthier World, especially when there are many other exciting alumni events happening throughout the weekend. And this afternoon, I personally walked through Washington Square Park to get here, and it was a whole thing. So I know you could be other places. Thank you for being here with us. I'm Deborah Verholden. I'm the Dean of the NYU School of Global Public Health. I'm pleased to welcome you all here today to this moderated discussion. Following the discussion, we're going to have Q&A, and we're going to talk about how innovations like AI and data mining, machine learning, and cloud computing can create a more efficient, equitable, and ethical healthcare system. Our esteemed panelists this afternoon are part of the work that brings GPH to the forefront of public health tech. I'm going to start off by introducing Dr. Bill Weeks. He's the director of Microsoft AI for Health Research, where he collaborates with academic institutions and nonprofits to conduct research on the economic and business aspects of healthcare services utilization and delivery. He's also an adjunct professor at GPH. Dr. Rumi Chinara is the director of the NYU Center for Health Data Science and jointly appointed as a professor in biostatistics at GPH and computer science and engineering at NYU Tandon. Her research focuses on developing computational and statistical approaches for acquiring, integrating, and using data to improve population-level public health. Mr. Vincent Lopez is the founder and CEO of Parker Health, a biotech company and creator of Parker Suite, a cloud-based platform for improving interoperability, that's one of those words for me, between programs used by healthcare providers. He also serves as a member of our GPH Dean's Council, and he doesn't like to brag on this, but I do. He's also a Forbes 30 under 30 in healthcare. Yeah. Lastly, I'd like to present our moderator, Erin Schumacher. She is a Politico reporter who covers the future of health. And I just want to say we so need credible messengers in that space. So Erin, thank you for all of your great work. Just a few housekeeping notes before we begin. Following the moderated conversation, we're going to take questions from the audience. We encourage you to submit your questions over the course of the talk on the form linked to a paper with the QR code that's on your seat. If you don't have it, chances are you got to raise up, pull it out, and if not, there should be one on the seat next to you. For those who are joining virtually, don't submit the questions through the Q&A feature. Instead, use the link that's posted on the chat instead. Following this event, we'd like to invite you all to join us at Rosa Mexicano in Union Square for an alumni reception, and I want to acknowledge Deron Kidd, the head of our Alumni Association, from 4 to 6. Now, please join me in a warm welcome to our esteemed panel.
Okay, good afternoon, everyone, and thanks so much for being here. Over the next hour, we're going to talk about the intersection of two exciting fields, public health and technology. We'll dive into the promise of AI and telemedicine in making our global society healthier, as well as some of the potential downsides of cutting-edge technology, like bias and misinformation. And then my favorite part of these discussions, we're going to dig into what working in these fields are actually like. And just a quick reminder, I know you just heard it, but submit your questions through the QR code. I'm excited to get those, and we can address them at the end of the program. So let's get started. Thanks for joining us. Now, for me, a sort of light bulb moment in realizing the potential of technology in shaping public health was during the pandemic, watching these COVID-19 dashboards pop up with this data that anyone could access. I thought that was very exciting, but it's been a couple of years since then. Bill, I want to start with you. I'm curious, what's a tangible example of something you're working on right now at Microsoft that bridges those two fields, technology and public health?
There's a couple. One thing that we have, and first, thanks for having me here. It's great to be here, and thanks for coming out. We have a couple things going on. First, we're working with NYU, with Jose and G and others here to to try to identify the relationships between social determinants of health and health outcomes, particularly cardiovascular health outcomes. And kind of as part of that effort, we developed another dashboard similar to the COVID one that Microsoft actually developed early on, which is the health equity dashboard, where we're trying to look at the county level, look at social determinants of health, and understand differences across the country, with a particular emphasis on economic differences that kind of drive social determinant of health differences, and as well as rural-urban ones.
And for people who might not be as in the public health world, what are social determinants of health?
Sure, social determinants of health. I wish G was here to help me with this, but they are in essence, the conditions in which we live and work. So the reality is that social determinants of health kind of determine 60%-ish of your health. Health care, like what I did when I was a physician, when I still am, but in the physician realm is more like 10 or 20%. So changing social determinants of health is likely to have a much higher kind of return on investment to the health of the population than investing more in healthcare facilities, for instance.
Great, I think that's a good summation. Vince, I know you're doing some innovative things at Parker Health with health data. Can you talk a little bit about that? And I'm especially interested in your electronics records work.
Yeah, we build electronic health records. We're the most compliant in terms of all the new standards with FHIR, some of the interoperability pieces that we hear about. And really what's important in this piece is where we're utilizing data. You'll notice in the healthcare world, a lot of our data is very stagnant today. If you've experienced that in your own primary care experiences, and you're, can't find medical records, having issues getting prescriptions filled, et cetera. And so a lot of what we're working with is really looking at some of those tangible pieces, right? Bringing the tech to the world that needs it, but also understanding that, coming back to our SDOH focal points, is that a lot of these communities that are SDOH don't have access to this technology because of the cost, and also the accessibility in terms of having physicians and other providers having the experience and understanding of how to use this technology. So we've really been making it more efficient in terms of use cases in rural communities, also in super urban communities such as New York City, Chicago, et cetera, and really bringing a lot of those services to the front and the forefront of where we are in health tech today.
Yeah, I'm interested in those rural communities, especially places that might have less access to technology. How do you, go about getting that data?
It's very difficult in many respects from a rural healthcare perspective. You have multiple things that kind of coalesce. You have, one, the accessibility for digital health technology to be deployed, but then you also have the infrastructure of our telecommunications systems and services in those rural communities that are very much impoverished. And so when you have cool tech like what we're building or what Microsoft or others are working on, it's hard to deploy those in communities that don't have telecommunication infrastructure. And so a lot of that is working in tandem with government, local government, and federal government to bring that to light. And we saw a lot of that during COVID in our deployables across COVID of, here's a makeshift clinic, here's a pop-up satellite facility that could operate and manage certain satellite programs, right, for technology. So it's a big lift. It takes a village.
Yeah. Rumi, for you, I know you do some mining data in unexpected places, like cell phone data, social media data, satellite data. Can you paint a little picture for us of what your work in that space looks like?
Yeah, so good to see everybody. And here in our School of Public Health, where we study all these things and kind of bring these worlds together also. So we know we have new technologies like on the front lines, like Vince is building electronic health records. We know we have new forms of artificial intelligence to use data, and so we're kind of researching how we can leverage that all within a public health framework, right? So getting better measures of those social determinants, which we know are not going to be often captured in the EHR, right? So which data should we prioritize? Which one's going to help our providers work with patients better that they have social determinants? So we look at getting those measures. So for example, using satellite imagery to measure green spaces in different communities, because we know green space is so important for our mental health, for our physical health. And so not only getting better measures of those, but then thinking, all right, if I want to know something about our community, is it going to be more helpful for me to move the needle on making more green space, or am I going to budge people's physical activity? And doing those kind of data questions so that I can help make those decisions better for the providers or at the policy level. And so we, get the better measures, from satellite imagery, like I said, and also other types of measures, like what's online can also translate to our real world, right? So if we see a lot of negative things online, that can get under our skin too. So we study how that gets under the skin, and then complementary to things that Vince looks at in terms of electronic health records, how do we prioritize which things to put in there, right? Because we can't put, it'll have to be organized in some way. How do we prioritize those items? And if we want to look at like risk, like predicting someone's health, how do we decide which aspects to put in that are going to be more predictive for different groups?
Right.
So that's a whole sphere for you.
I mean, how do you decide which aspects to put in? Like,
that
seems tricky.
That's a good question, right? So it's like, actually, as Vince had said, it's not just a methodological question, which makes the model fit better, which makes my prediction better, but also working with who is going to be using that information at the providers or governments, what's going to help them make a better decision in their work stream, right? And so that's how we kind of leverage the public health principles alongside these new technological developments. Yeah,
that's interesting. I mean, I do love that we've got academia represented here and industry, and I want to talk a little bit about collaboration. In what areas are those two entities already doing a good job, and then where's there some room for growth?
Yeah. Well, I talk a little about some of the work we're doing here with NYU. So obviously I'm a member of the Dean's Council, but I'm also launching what we call Lopez Clinical Innovation Studio here at NYU with GPH. And we're going to be doing a lot of work within our platform and looking at SDOH data, Black and brown maternal health programs, and kind of developing what some of these infrastructures look like today. And we are going to spend a lot of time with that. And I think it's very important to bring industry into the academic experience because, one, you're enabling students to get hands-on education, but also hands-on with the technology and what's happening in industry. But you're also creating a conversation that's a dialogue. And I often think that in the industry and in academia, the conversations go non-parallel. And so it makes it very difficult for us to really be on the forefront and to keep students both academically engaged, but also prepared for what's to come when they enter into the real world. And so having that parallel conversation is very dynamic in terms of really bringing global public health to the forefront. And again, we didn't really follow public health much until COVID-19 hit, and suddenly everybody becomes a global public health expert, right? And so, in looking at that, really, that's why having these partnerships with the university at an academic level is very keen to what we're doing in order to prolong our ability to be successful both as a company, but also in making a difference in your lives.
Got it. And Rumi or Bill, is there any room for improvement there? Any ways that those collaborations could be better, or maybe aren't reaching their full potential in some way?
Go ahead.
I mean, there's always room for improvement, right? So to me, the greatest opportunities would be inclusion of the students, frankly, and ramping them up. Because, academia is, I lived in that world for quite some time. It's very different than industry. And the transition can be tough. But I think experiencing it can give them almost better informed career decision making, right? Because they can see what that's like. It's a different pace. It's a different kind of level of rigor, to be honest. You accept, like we were saying, it's not what can I do in a 10-year portfolio, but what can I do by next Tuesday, right? And so you want to get kind of directional. Yes, much more directional. It's much more shorter term and much more, the pace is just very different. So I think it's good because some people like that pace, some people don't. And if you're going to be working with industry, you need to be able to kind of translate across, and understand the different paces.
Yeah, I would just reiterate everything that Vince and Bill said. I think it's bilateral. So for us, sitting like in the classroom, I want to make sure I'm equipping my students for what is going to be helpful for them to get that next position, to get that job. And things change very rapidly, especially in this space. When I became a professor, deep learning wasn't even a big thing. Now you might hear a lot about deep learning, like large language models, like a lot of AI words that didn't even exist at that time. And so it's good to have that interface with industry so we know what's coming up. We know we can better prepare our students, and we try to have that relationship. And just like Bill said, it's helpful to help students ramp up. It's also good when my students go off for an internship and they come back and they've seen that world, so then it benefits us on this side so they can do their research in a more, strategic way as well. So it's really a good, a bilateral approach.
Yeah, I would just add too that, I mean, we get a lot when the students are there too, because our pace is often too fast, to be
Okay.
honest. We run to get the thing and we don't think. And the great thing that academicians do is they think, and they take a few minutes to get the question right. So that's been a balance for me, because it's critical. If you're not answering a question, I don't know exactly kind of what you're doing in research. So it's critical to get that part right. And sometimes we get a data set and we rush to put it in and push buttons and see what comes out without kind of knowing what we're doing, which can be, frankly, a little dangerous. So
Yeah.
I think it brings kind of an ethic and a little more thought to the process if you have this interaction.
Right.
I love that kind of a little check and balance there. Vince, you had mentioned government, which I think is the entity we did not talk about yet. You've worked on programs for the Department of Homeland Security and Defense, and I know you live in DC.
I do, yeah.
How does government fit into this
Yeah.
collaborative picture?
Yeah, I think government is it's huge in healthcare, right? Healthcare in the United States is funded primarily by government, right? Subsidized across Medicare, Medicaid, other military programs, et cetera, that fund this. But really, what we look at now is kind of where government is addressing healthcare, right? Your NIH is most famously known for research and new discovery of diseases with CDC, et cetera. But now you're getting into the programs with ARPA and DARPA that are really putting a lot of money into digital health experiences and looking at ways that we're using the digital healthcare programs, right? But also where we're micromanaging data sets, right? A lot of our data now is very raw, and it's not being addressed appropriately. And I think you'll notice that from the academic side as well in research, is that we are not sure how to use the data. We're trying to figure out how we're using it, and a lot of that is the same questions the government's asking. And you come into the conversation where you talk about artificial intelligence and machine learning, and you talk to policymakers who are trying to regulate something that is really unregulatable at this point because people are still trying to figure it out. It's a lot of R&D. It's a lot of, failures and survival of kind of the fittest of who's going to do it. But at the same token, it's really important to have those conversations with government and really bringing them abreast. And I'm fortunate enough of not only just living in Washington, but also having the relationships there that I can address some of the things that we're working on in healthcare, right? And what Parker Health is bringing to the forefront in terms of how we're using data, where we're using data, who's having access to it, and what do those accessibility reaches look like. And coming back to AI machine learning, what's being used in a clinical experience. And a lot of it is that we're not really trying to replace a physician or try to replace the provider. We're trying to give them tools to enhance the experience for both them and the patient. And at the end of the day, a lot of it is about creating opportunities for them to become better physicians and for you to become a better patient. And that's important for the government to understand because you can't regulate something you don't know about.
Absolutely not. So we have talked a little bit about where we are currently, and now I want to talk about what's next. Bill, I'm curious, we've got AI and big data. Would you say that they're changing the way we approach public health in any sense?
I think so. I hope so. That's kind of what I banked my career on. So, yeah, I think, the challenge heretofore has been that we've had data that's been in isolated silos and they haven't been able to be integrated and haven't had the compute power or the storage to actually analyze it without having really a somewhat biased perspective. I got to limit my variables and I have to use linear regression or something like that, which it's, much of life that we experience is not linear, surprisingly enough, right? And most interactions are not as well. So to capture that is kind of a phenomenal opportunity. I do think, I think most people maybe in the audience, or most people I talk to, when they think of AI, they think of November 2022 when GPT came out, and that there was no AI before that, which is not remotely the case. But I do think that GPT, the large language models have a tremendous opportunity to do two things for health, to shorten, you guys who are in public health know about this 17-year gap between when we know absolutely this works. We've done 23 randomized controlled trials, and a mere 17 years later, is it in practice? That should shorten substantially, I think, with the use of these models and with AI kind of feeding in as Vince was saying, to help support providers in making the best decisions. The other part that I think it will help with is shortening or narrowing the variation in quality of care. Everyone who goes to a physician, you probably go to their physician because your brother's cousin's wife recommended that person, or they have a nice office or something like that. You're not necessarily choosing based on the quality of care that provider provides, particularly for the thing that you need. So I think the AI models can tremendously help with that, and the GPT models in particular can be helpful in responding to patients who say, where you can ultimately, my hope is ultimately say, I'm a 60-year-old white male that has this kind of pain in my right knee. Should I get a knee replacement or should I have medical management? And if the answer is, yeah, you should get a knee replacement because everything indicates you'll be better off in 10 years if you do that, the second question is, where do I get it? To whom do I go to get that? Who's going to maybe, I think, ultimately, we'll have people who specialize in right knee replacement and left knee replacement because they will do better at that thing, and that will be evident in the models. Mm-hmm.
Nice. So we've talked a little bit about AI. I'm curious, Vince and Rumi, are there other technologies that you're excited about, even if they're not fully realized yet, that might be coming down the pipeline in your,
Yeah, so one of the things we're kind of working on our end is predictive modeling for care management. So it's not fully realized in terms of out in the office and running it, but really on that model is really looking at where we're managing care, right? We can predict patients that have certain comorbidities that might have an outcome in the next 10, 20 years, right, based on who they are, what they do. And so one of the examples I give often that we've been studying a lot is diabetics, right? These are the comorbidities that come with being a diabetic. Your increased chance of having a heart attack, stroke, or other cancers, et cetera, are now much significantly higher. This is what this looks like in 5 to 10 years. And so we're creating some of these models now. Again, nothing is out there on the market yet, but it's really where we're going in healthcare. And the big thing that we really raise concerns about is, are we using correct data sets for this, right? Is it racially biased? Is it age biased? Is it sex biased, et cetera? And really creating a dialogue that makes sense for everybody. And I think that's the real scary part now in terms of where AI is going and machine learning, is that are we just kind of throwing everything into a bucket and then hoping it makes an error or a mathematical return that we want? Or are we actually being smart about this and being methodical and senses of what we're collecting and where we're showing that? And a lot of our data sets would tell us that they're all skewed, because most of them are now. And so that's really where our big concern is that I don't want to just predict the model of what your experience and care model would look like, but I want to be able to predict it appropriately for your age, your gender, your race, et cetera. Because again, when you look back at healthcare, our SDOH is 90% of our population, and so we want to make sure we're applicable to everyone. And that's a lot of refining.
Rumi, do you have anything to add to that?
Yeah, that's definitely there's a lot of exciting things on the horizon, and I think just kind of building upon Bill and Vince were saying, I think technology can go in many directions, and I think one of the exciting things, especially as alumni, as people gone through like your education, is really looking at like leveraging those principles that we learn in order to make those technologies. And what does that mean? That means like when we're thinking about prediction models, like Vince already nicely discussed, and as Bill mentioned, a lot of what matters for health, of course, quality of care, access to healthcare, but a lot of what drives our health happens right before we get to the hospital. So are we using our technologies to think about those parts also, whether that means, capturing those environmental factors better, and one of the things we're working at the medical school here is thinking about helping patients in their own home, like diabetic patients. Diabetes is something, it's intensely management heavy. You have to monitor your blood glucose every day, more than one time a day. So how can technology help you do that? And how can that happen in a way that kind of couples with what we know does work in terms of getting maybe a helping hand from a nurse practitioner or something? And how can technology help them do their job better? And so thinking about all those kind of upstream factors that we all learn in public health, and can also help us, build technologies that I think will be really exciting and really helpful for everybody.
Yeah, with what you mentioned about treating some of those conditions at home or monitoring them at home, it makes me think a little bit about telehealth, which I know that you've got some expertise in. And I'm curious if you have any, 5, 10-year predictions for telehealth and what that could kind of look like.
Oh, that's a great question. Well, I'm curious to hear what Vince
Okay,
thinks
yeah.
after. I'll go to him after because, my work's mostly been with the medical school here. Yes, I think definitely we're all, as individuals, as like patients, we're all becoming more savvy. Like you mentioned, the COVID dashboard, we can all see information that we have. And we're definitely going to see that more. I think one of the let's say, challenges we're going to be overcoming is like, how do we make use of all this information, right? If I'm monitoring my blood pressure every day, how is that useful? If I want to put that into a prediction model, does it matter if my blood pressure was off for 1 day or 5 days, right? And so we're kind of needing to unpack a lot of that thing. So those kind of we have much more data, how to use that well. But I think that's kind of the next questions, and that'll enable us to be more savvy, both us at home and then also maybe our providers when we come in to see them. But yeah, let's hear from Vince also about what's going on in this space.
Yeah, I mean, telehealth is changing a lot. I mean, I think we've all experienced it through COVID, and kind of getting on Zoom calls, and then it crashes, and then it comes back online again. We've all seen it. And then you've also we're getting really heavy into digital prescriptions, right? E-prescribing, et cetera. And when we look at digital health, it's definitely changing. There's a lot of things that you can do through it, but there's a lot of issues with it long term, right? And in terms of delivery of care, and I think Bill can echo this from the physician side, that you lose a lot of that interpersonal experience with your patient. You also are very much limited to the resources you can fulfill, right? You can't do an MRI from your living room, right? I mean, that'd be great, but you can't. And so you have a lot of these experiences where now you're referring folks out to other tertiary care level experts to get things done, and then you have a consultation with your physician via telehealth. It makes sense, it's great, it's convenient during COVID, but I think for where we are, our science and technology has to catch up to be as beneficial. But also, we're going into like what they call remote physiological monitoring, the RPM, RTM space in healthcare. And a lot of that is, I have my own positions on that in terms of how the billing codes and all of that align and if we're actually meeting the regulations for that. But in terms of that, that's where we're seeing a lot of experiences. Folks are now wearing wearable devices, right? You have an Apple Watch, et cetera, and you're reporting some of those data measures back, and people are evaluating that with the data. The qualm to that is it an FDA-cleared device? Are you getting medical-grade data and technology sets that can be used to make a clinical determination? And we're not, right? We're not seeing a lot of that. There's only certain microisms of each thing that work for the long term. And so I think we have a lot of R&D still on that piece. And in terms of delivery of care, we've got to fix it in person before I think we can really nail down the telehealth version of it. So,
Yes, a little bit of a realism there.
absolutely.
Well, on the topic of realism, there's so much excitement around health technology. Bill, you mentioned ChatGPT and large language models. How do you discern what's tangible innovation from hype?
There's a lot of hype,
I agree.
and there's a lot of fear, right? So Politico is the right person to talk to about this hype and fear. Because I think the question, you could ask people raise their hand, is AI going to kill us or save us all, right? And we're pretty divided on that. So I think it just, just like anything else, there are advantages and disadvantages, right? When we get out of bed in the morning, we're taking a risk. There are risks in life. There's risks when you go to the doctor. In the U.S., since 1992, when Lucian Leape came out with this study, it's been repeatedly demonstrated that there are about 100,000 deaths a year associated with medical errors, right? Mm-hmm. There's risk in life, there's risk in medicine. The key thing to me is can we reduce that risk and again, bring up the people who are not getting adequate care, particularly if we think about the world and not just the U.S., the 4 billion people in the world who are getting inadequate or no health care. Can we enhance their healthcare experience by having these models and do it imperfectly? Will it be perfect? Of course it won't be perfect. Humans aren't perfect. The models won't be perfect. We need to test them. We need to make sure that they're safe. We need to make sure that they're not biased. But I think there's this huge opportunity to raise the bar so that quality dramatically improves for pretty much everyone. Because the challenge I have is that often when you see in academic papers the GPT compared to physicians or something, you look at GPT compared to the top 3 physicians in the world in this particular area, and GPT may only operate at 80 or 90% of what they're achieving. That's pretty good, because the vast majority of the world is not getting even 80 or 90% of the top 3 people in the world in a particular topic. So I think we need to think rationally about what we should expect from these models, what is improvement compared to now, and use them in that way, testing them all the way, like I said, being responsible, being sure there's not bias and things like that, or minimizing bias. There's bias in our healthcare system, right? To minimize the biases that are there, to try to really enhance population health, because I think that's, to me, the earlier question about the government is kind of the end user of a lot of these products, because they are the financiers of almost all health in the world, and what we care about is the population health, and so that should be our metric. Are we enhancing that?
I mean, Bill, you've mentioned bias.
Yeah.
Vince, you've mentioned bias as well. Like, let's talk about some of these potential pitfalls. Like,
Sure.
that seems like one of them for sure.
Yeah, death's always one of them.
But what does that even mean? Like,
But,
what is bias in these?
Yeah, I think for bias, for myself, obviously I'm Mexican American, I'm a minority. So, we have a lot of data sets and things that we don't address internally within our own populace that we just don't know. We have unknown answers to. And so in terms of bias, really, we're looking at things that are unknown to us, right? The people that are the developers of the technology, the science, et cetera, that really rely on our everyday people to have those conversations. And so to pick up where Bill's going, a lot of it is really that folks are into the hype, right? It sounds really cool. It's really, really awesome. The problem is that they're not willing to be a part of that experiment, to be understanding of how this testing and learning goes. And that also, you can't just have AI. It's a machine that you have to train and you have to teach. And so it's no different than training or teaching a student or an individual to do something. It's the same process. And so it takes a little bit of a learning curve. But in coming back to some of the bias points is that we want to make sure that we're not targeting certain populations, certain demographics, one way or the other, and skewing data. And we do enough of that in healthcare now, and a lot of that in pop health data too, where we just kind of aggregate all sets of data and we say this is the number. We saw a lot of that during COVID, right? Numbers were higher, sometimes they were lower. Certain populations were more advantageous in being susceptible to it, right? And so we really want to be as cautious and as remedial as possible in terms of mitigating that before it goes further south than where we've gone today. And so bias has a lot of meanings. I think it really just depends on who you are as an individual and what your kind of focal point is, with your organization's work.
Yeah, it seems like the task is not baking the human bias into our new technology.
Right, and it's hard, right? Because one of us has to build it.
Rumi, I want to know from you, we've heard a lot about these optimistic takes of where health technology can lead us. What do you make of the argument that sometimes health technology ends up serving people who are already well off, already have good fitting, and kind of leaving behind people who have fewer advantages?
Yeah, so I think just like Vince was motivating, it's important to consider not only when we're getting data, we're building a new technology, and in general, what tends to happen, and we can all see how this might pan out, is the technology. Let's take the example of telemedicine. Obviously, folks don't have a good internet connection. They're not going to be able to use and make use of the telemedicine and benefit from that kind of service, right? And there is a nice I'm such a visual person, I like to think about a structured way to think about it from some of the research around kind of like what happens when things become inequitable is kind of those kind of, let's say, more foundational or sometimes like upstream kind of factors is where a lot of the inequities can kind of lie in. So, for example, if I don't live anywhere with like nice sidewalks, I feel safe to walk around, I'm not going to be able to exercise as much, right? See how like a lot of those kind of foundational upstream things need to happen. And a lot of times, data is so powerful, it's so useful to make decisions, to make comparisons, but it's we tend to like individualize when we talk about data, meaning it's always like factors about me as a person only that I'm capturing, right? So, but we know that we want to make sure that if I have a new cool satellite imagery model that looks at how green spaces are, it's got to work well both in in the urban places and the rural places, right? So we need to think about those factors as we're designing. So hopefully that helps people see how it's kind of easy for things to kind of become inequitable, but it's good if we're thinking about it in that way, we can proactively design to, to address for who needs it in advance. Yeah.
Are there any other pitfalls we didn't talk about that any of you want to bring to light here?
So I do the most boringest thing in healthcare, right? I'll just go there. Because it's the biggest pitfall, I think, that people don't think about. So electronic health records, you're like, who needs an electronic health record? It's boring. It's not sexy. It doesn't do these like really cool things that you would think of. We do, by the way, now. There are bells and whistles we've added on. But in terms of what the technology does is, right, in order for Bill's team and for Rami's team to do the research and the R&D on a lot of what we're doing, you need medical data, right? You need patient data. And you need that data to be as clean as possible and as lively as possible in terms of the data sets and structures. And so us as an EHR platform, we are really the foundation of what starts in the science and development phase of building out certain data sets and allowing them to come in and build out all the cool bells and whistles that you guys like, right? Or that investments in venture capital like to invest in, right? And so, unfortunately, somebody's got to do the dirty work, and we like to do that, right? And it's fun, but it allows us to really get on the ground level of what's happening in our healthcare experience. And I think that's the biggest pitfall in terms of building out all of this wonderful things of AI machine learning. It all comes back to a foundation of where data and health records sit, where that data looks like, moving it out of a siloed environment into a cloud-based environment, and enabling opportunity for us to really start to do this. And so when you look at kind of our competitors in the space, or you look at folks that are in the space now in healthcare, it's antiquated systems, it's antiquated data sets. And so a lot of that data is now dead and gone, right? Because you can't migrate data from an on-prem setting to a cloud-based setting sometimes due to data sets that are just missing, or things don't compute anymore, right? Because we're in the 21st century. And so you look at a lot of that, and that's really where some of the pitfalls really lie in terms of managing that data set.
So I think this is a good chance to pivot to my favorite part of the program. I'm confident that there are some people either in the audience or online who think our panelists have very cool jobs and want to know, how they landed them, what it's like to work in them. Rumi, I'd love to start with you. I know you studied engineering before going into public health. What prompted that decision, and how does that background inform your public health?
Oh man, okay, that's a great question. How long do we have? Great, so I guess one theme I would say is that, and I would just, encourage everyone is, sometimes we would think, okay, when I graduate, I'll have like a perfect job and I'll stay in that for like 30 years and then I'll retire. And these days, as we can see, it just, for many reasons, it's not really the case. And I just wanted to put that out there to like make people comfortable. It's totally fine. And it's probably going to happen. Like I mentioned, when I became a professor, like deep learning wasn't even a thing. So, but I think the fact that I studied something in college, in this case it was engineering, I became comfortable like looking at new problems, like, okay, I have to solve this new problem. What's the process by I go about that? I felt okay doing it. That was really helpful. And so really want to encourage students and anyone who's looking around at like, how they're spending their time and what their days are. And it's okay to be open to like new challenges. And in fact, it's helpful. And, spending that time to really embrace it, even if it's not like what exactly you thought in your head, because I didn't know what I'm doing now existed when I was a student, let alone could have pictured it. And so kind of just being open to new challenges was really important to me through my path. Yeah.
Thank you. Vince, was your path as twisting? How did you come to found Parker Health?
Yeah, basically. It's a journey. I've been working really on Parker Health quite a long time. I've probably in middle school, high school, I started writing a business plan on kind of helping make healthcare better in the world. And these like three dreams we have as children that we're going to make the world a better place. And so that's really where I went with it. I've been in the healthcare space since I was in high school. in terms of working in a hospital, working on an ambulance, EMT, medic, all the fun stuff. And really having a lot of hands-on experience from a young age really showed me what was happening in our healthcare system. And then working obviously in the policy space, right? And realizing where there was pitfalls and where we could make opportunities happen. And ultimately in healthcare, like most of our industries, you need regulation and you need policy in place to make the ship continue to sail on. And that's really where I went, right? And I looked at where we were having shortcomings in healthcare, where were we creating kind of these stifling problems that continue to exist. And a lot of it came back to data management, right? Where is our patient data? Where is our records? Where are those populations that we've been working in for so long that we don't have data on, right? It's concerning. And so that's kind of how I got into it, right? In a lot of spaces. So I founded the company. It's going on 4 years now. We're doing quite well. We just came off of a Series A and continue to grow. And so very excited kind of where we're going and the trajectory of us as a company, but also really the impact that we're making. You know, I think oftentimes you'll see it in healthcare now. Everybody's jumping in it, every major company, because it's a lot of money in it. Government's paying for it. But at the end of the day, it's really about the impact that we're trying to make and trying to leave an everlasting change in our healthcare administration, but also within the way that we're training and teaching students as well. So.
Yeah, I have an interesting follow-up for not just you, Vince, but all
Sure.
three of you. Speaking of impact, like if you were mentoring a student and they came to you and they're interested in public health technology and they wanted to know where they could make a big impact in that field, how would you guide them? Would you like to start, Bill?
Yeah, that's a good question. What I tell kids to do is look for where the Venn diagrams intersect and translate. So no tech or no public health or no medicine in public health or some combination thereof, because to me that's where the value really is, that translation. The guy, I went to business school, and that was a wonderful thing for me because the business guys don't get medicine and the medicine guys don't get business. I mean, when you go into medicine,
Very true.
you have never taken an accounting course by the time you get through your residency. So just being able to kind of translate that and show how we're all working on this common goal, guys, and then they can kind of come together and work together. Mm-hmm. Short of that, there's this kind of conflict and stuff like that. So to me, just look where the Venn diagram is in something that you like. Don't do stuff you don't like. Don't work with people you don't like. And I would say my career path is just, be lucky. And the way to be lucky is to frankly show up, be there, and finish stuff. One of my early mentors told me there are two types of people in the world, people who finish and those who don't. And the finishers get the opportunities. And then they're lucky, like me.
I need your luck, Bill.
May we all be so lucky for me.
Yeah, well, I think I like the Venn diagram approach, and I would say, maybe another circle, or and kind of building on what Bill said is, look how unique value you can bring. We're all all have such different paths and experiences, and I think really, looking at that as an important asset is great. And sometimes it takes a little bit of work to do that because we kind of see how things are going and how things should be, but remember that you can also bring something unique to that same synergy. And also to what Bill said, I totally agree, is whatever you're doing, take some time, do it rigorously. It's easy these days to kind of have a shorter look at things or think that things aren't easy and just kind of not pursue, but we can all do it. And even if it's not your initial idea of the most important thing, getting that practice in doing something to the end is super valuable. Yeah, you can build that muscle. Yeah.
Sounds like we all want to hit our deadlines, complete our projects. Got some things I could finish up. Yeah. Vince, what do you think?
I would just say jump off the cliff. Really, and I mean that both literal and metaphorically. I think oftentimes us as young adults, right? I can speak. I mean, your guys is probably much older than probably some of you guys, maybe in your age range. But in terms of that, I think really is really kind of just jump off and do something, right? If it's something you're passionate about, something you believe in, and there's something there that's tangible to access it, right? Obviously, you need to have something there to protect that, but jump off the bridge and do it, right? Jump off the bridge and do it. I jumped off the bridge and said, I'm going to do my company because I know I can do it better. We can build better. We can make something happen. I think that's where a lot of us get tied up on, right? I think all of us just kind of like, oh, we're timid, we get afraid, we see everything that everybody's telling us not to do something, right, because of X, Y, Z. Obviously weigh your calculations, but at the end of the day, you have to jump off the cliff and just do it. Otherwise, nobody else is going to do it, right? And some of your most successful people in this world have just jumped off the cliff, and you will either sink or you'll swim, and one way or the other, it'll be one of the great lessons you'll learn in life. So that's my take on it.
Get in, go swimming, get messy. Do you have any recommendations for people that just want to dip their toe into this kind of work? Books or podcasts or newsletters or blogs or just things that maybe you read or that you'd recommend anyone who's interested in this field take a look at?
I'm a nerd, so probably stuff that nobody wants to read. Like NIH has a wonderful library of updated research. So does ARPA. The National Medical Society Journal has wonderful material as well. I think really if you want to look at what's kind of happening, also a lot of large companies like Microsoft and others have centers that are online that you can pull a lot of data from, right, and have a lot of meat to the potatoes of kind of what's being out there.
Okay. Approachable.
Read The Economist.
Yeah.
It is exceptionally good at thinking about the future, and it is really well written. And if you are going to communicate in writing, it's a really good thing to study.
Anything to add? Yeah, I think those are great. There's a lot of, I think sometimes we feel overwhelmed, I think, because there's so much information out there, but I think these are kind of like well-known sources, and if you're looking more from like what's the research going on or what are the main companies doing in this area, I think that's a good place to start, yeah.
Yeah. I would also say attend conferences if you can too. A lot of the big health conferences like Health, HIMSS, et cetera, they have a lot of free invites for students as well, so you can get access to that and really kind of meet some of these folks that are building this stuff and on the ground with it. So I would highly recommend that.
Yeah, that's smart.
And they're a lot of fun too. So.
Very smart. And then this is the last question from me, and then we can take some questions that the audience has sent in via the QR. But just for a last lightning round, what motivates you to do the work that you do? What gets you up in the morning?
I want to save the world. That's why I got into healthcare, and I actually, my career path was starting with clinical work, which I didn't find all that intellectually stimulating, to be honest with you. And I thought that policy was a much more kind of influential thing, and now what I do, I think, is pretty influential to the world. So we have the tools to help particularly vulnerable populations do better in life. We have an obligation to use them for that purpose. That's why I'm here.
What motivates me, I would say all of you actually, because I feel, there's so many innovative, awesome things that, all the different work communities have been able to do, and just imagine what bringing in all these awesome minds to that fold could do. So that's what gets me up every day. Yeah.
Yeah. I would echo with Bill as well, changing the world, right? Making an impact that's bigger than ourselves, and really bringing something that kind of enables us to be better humans and better people, and really contribute to kind of the future where we're going. That's what motivates me, right? Every day I wake up and I'm like, let's go. So.
I love it. I think that's a great note to transition to our audience questions. Thank you for sending them in via the QR code. Okay. First question. With the advent of new techniques in early detection of disease, such as pan disease, early detection of degenerative diseases, and pan-cancer screening, much of which are driven by AI innovations, are we at risk of adding unsustainable strain in the middle, treatment, infrastructure, and back-end funding? In essence, is the rapid innovation detection and prediction likely to cause poor outcomes due to limitations in delivery of care? Okay, rapid innovation, is that likely to cause poorer outcomes? Who would like to take this one?
I can start maybe, and then the other folks. Yes, I think it's a great question because there's always that the paradigm of like, well, was it a better detection or was it just improved diagnostics, right? And then of course, but I think I guess I'm not going to give an answer to it specifically, but I'll give the approach, which I think is good, that we have research going on kind of in multiple levels, right? So not just considering the diagnosis quality, but also how does that impact on the system, right? So if we look at the population level, well, what's the shift in the early detection going to do for longevity, or what is that looking at different levels, at the system level, economically, what's the impact going to be? And so that's the importance of thinking at that like systems level, which we have a lot of good research happening, and maybe these have to kind of catch up to each other, but that's, I think, an important view. Yeah.
And then Vince, we have a question for you. You talked about rural health, both in terms of access to care and access to technology. The question is, I'm wondering if you can speak to this work globally, both potentially in rural settings in other countries.
Yeah, absolutely. So I've obviously gone to the World Health Summit many times. I didn't go this year on travel constraints, but in terms of what we do, yeah, we do work globally. We work with some folks in North Africa, East Africa, and some of the issues that we address is the same issues on the global scale that we have in rural healthcare here. You have a lot of these countries that are underdeveloped or developing, and they don't have access to the same technologies and infrastructures that we have here. That make it very challenging to deploy some of these new and innovative technologies, whether it's our platform or other research and technology tools like diagnostic tools. And so, yeah, it's very cumbersome. But a lot of it is, again, coming back to government and policy, right? Working with our larger entities that have oversight on this, World Health Organization, the United Nations, go down the list, and really having those conversations to really engage and have some of those come to the table. So.
Rumi, we've got a question for you. You mentioned that we're doing things now with AI that were not even in discussion years ago. In the next few years, what do you think's on the horizon?
Okay, that's a great question. I guess, yeah, that's, well, stay tuned. But no. But I think, maybe I can just give some broad brushstrokes, which I think will be important. As many folks in the public were able to interact with this ChatGPT. It works a lot with like looking at text online, like natural language. And the same kind of things are happening on the images side. So these are different types of data. So I think we'll be able to like bring multiple types of data together maybe. That's like maybe one of the directions we'll be able to see things going forward. Yeah, and I'd love to hear if the others have thoughts too. Yeah.
Yeah, I think there's a lot of things coming in tech. I think, the scary part, as I mentioned earlier, is are we being smart and deducive in what we're bringing into the conversation at the appropriate times. And much like your previous question about certain diagnoses and diseases, and if we're doing too much generative AI or too much research and development too quickly and giving outcomes too soon is concerning. And so I think a lot of it really is we have a lot of work to do. I caution that as at the forefront is that we have a lot of work to do in terms of R&D. We have a lot of conversations and dialogues that still need to be had in terms of what's being done. So I think there's a lot of opportunity to come, and I think it's a great time to get involved because you're on the ground level of that. But I also think we need to be very smart and cautious of what we're doing, and that we're not too rapid, right? And we're seeing, that backfire, and we've seen some of that in the healthcare space in terms of certain technology stacks already that have made things more challenging and have cost more money and have caused lives, right? So we don't want to be that kind of statistical process again. So.
Fair enough. Here's a question. I'm a recent NYU alum, and I'm really interested in health tech, but I'm having a hard time breaking into the field. Do you have any advice? Are there specific skills that I should highlight?
Hang out with her, I think. Really, this Venn diagram thing, you got to have some computer science or some other experience to get into there. It's tough. It's a tough sell just to go to a big tech company and say, I got an MPH. It's a good start. You need to have something to round it out, I think, and see what else you can bring.
Yeah. Yep, I would agree. I think you need to have a technical background of the product, of what you're trying to build in terms of technology. But really also understanding, I think the big thing in terms of digital health is really understanding regulations and policy. We need a lot of that in our conversations. I think having tech is great, having crazy mad scientists in the back making all these really cool algorithms, really cool, but I think the policy piece is very important because you can really create the niche, right? What you want to build and what you want to see kind of come to light through the policy. So if you're graduated with an MPH, please come to the policy side for health tech. More than happy to take you.
And then we've got one, how is the gap being bridged between culture and acceptance of health tech movements? For example, there are quite a lot of cultural stigmas against mental health. Are there any plans to explain scary technology to those of us, to those not in the health tech field?
Can you define scary technology?
Yeah, that's what I would.
I mean, I cannot be this question asker, but I think there's a lot of fear around technology. I mean, I certainly hear that, you know, amongst my acquaintances. Yeah, people are definitely scared of like, I think of AI and some of the therapy apps and things. Like, I can think of examples in which, yeah, people are nervous.
I don't know, Bill, you want to take that one?
Yeah, I'm a strength, so I guess I should take the question. Yeah, I think these need to be vetted. I think a lot of times what I see when people are pitching to us is that they say, oh, we did this observational study of 14 people and they got better. And okay, you need to have good trials, and you need to trial this stuff and make sure it is kind of safe and relevant and useful. I mean, I guess all technology, the kind of the intriguing thing to me sometimes is people are terrified of this, and then they're looking at their phones, which is recognizing their face, and there's no recognizing their finger. But, you know, the AI surrounds us right now. It's just the GPT is kind of new, but it is integrated into our lives, and we sometimes kind of just have jumped right in along with it as it's entered. So I think particularly around healthcare applications, you need to be cautious and make sure that it's safe. And there are, you know, a number of these are going through FDA kinds of approvals. I think the other thing you need to recognize, particularly if you're thinking about social determinants kind of interventions, is that if we do a good job at intervening, the risks will change over time. So it's not like one and done. It will have to be an iterative process and continuously kind of updated and reinvented and reapplied to different populations. So it's not going to be kind of, here's an off-the-shelf thing, just use this forever.
Mm-hmm. There is one other social determinants of question here for you, Bill, and that's what type of work is being done to center social determinants of health in health technology?
To center, I don't know quite
To
what
center
that
it,
means.
to bring it, to focus on it, to bring it front and center.
In health technology?
Is any work being
Is
done?
it getting at the bias kind of? Is that what the issue? I don't know quite what
I
the.
guess they're asking if
Yeah,
we're doing any
I mean,
work
my
in it.
interpretation of that would be, yeah, how is there, yeah, what's being done to integrate that into some of all of the health tech that we're talking about, I guess.
Wow.
Well, it's getting integrated, you know, through Z codes, for instance, in the billing processes.
Right.
And so Medicare and Medicaid are pushing this. The government's pushing this. They're capturing this stuff. There are obligations now for hospitals to capture this kind of stuff. The key thing, I think, is integrating it into the predictive modeling, so you can kind of, you know, include that in your modeling and think about that maybe it's not more insulin that people need, but more food to, again, have this return on investment to health.
Right. Yeah, I think to also echo off that too, I think that maybe the other piece is that the current SDOA kind of standards and questionnaires are kind of nonsensical, in my opinion. They need to be redone. So maybe that's kind of where you're going with that conversation, is if there's being new standards or things being developed or worked on. I would say yes. I would just say that it's probably not completed yet, but it's definitely, it's being worked on for sure. So.
Okay, I think I think we're out of time here, but thank you so much for your wonderful questions, and thank you so much to our panelists. It's been a pleasure.